Thank you very much for the opportunity to speak. I have nothing to disclose. So the small bowel has been referred to as a black box due to its long length, complex anatomy, and inaccessibility to endoscopists. However, recent endoscopic technology has begun to shed light on the small bowel lesion diagnosis. Small bowel lesions are diagnosed in a variety of ways, and they can be discovered by video capsule enteroscopy or deep enteroscopy such as balloon, double balloon, or spirus. With the latter, this allows you for early endoscopic interventions such as electrocoagulation, sclerotherapy, and hemoclip placement. Operative intervention remains the definitive treatment, though, when these methods fail. Small bowel symptomatology, small bowel lesions are extremely rare and actually represent less than 1% of all malignancies diagnosed in 2016 in the United States. They often present with vague symptoms, and at our institution, we've been able to classify them into two types of symptomatology: obstruction of abdominal pain, OP, and gastrointestinal bleeding and anemia. Therefore, we propose to examine the presentation, diagnostic workup, surgical intervention of small bowel patients with small bowel lesions and compare these findings based on their presenting symptomatology. We believe that since there's variation among their presentation, that there should be a variation as well in their diagnostic and treatment workup. Therefore, we performed a retrospective cohort in adult patients who underwent surgery for a small bowel lesion or suspected small bowel lesion at our institution from 2005 to 2015. Inclusion criteria included a preoperative diagnosis of gastrointestinal bleed, small bowel tumor, mass with or without obstructive symptomatology or perforation, small bowel diverticulum, and small bowel ulcer. We excluded patients that had small bowel resections without a suspicion of a mass, such as that they had suspicion for adhesive disease from prior surgery, or if they had any lesions in the duodenum. We also excluded patients who had inflammatory bowel disease prior to surgery. These patients were then divided into two groups as mentioned above, and statistical comparisons were performed between them. Overall, we had 112 patients that met inclusion criteria of our study. 60% were in the GI bleed group, with the remaining 40% in obstruction of pain. The average age was 62 years, 55% of our population were males, and 77% were Caucasians with no statistical difference. Patients in the GI bleed group had BMI that was 5 points higher compared to the obstruction and pain group. In addition, the patients in the GI bleed group had more chronic type symptoms, either presenting with chronic or acute on chronic symptomatology. When looking further at their endoscopic and their radiologic approaches for diagnosis, capsule study was significantly performed highly in the GI bleed anemia group in almost all patients. They also had the highest diagnostic yield of any study in the GI bleed patient group, with 67% of these lesions being identified in capsule and confirmed with intraoperative findings. On the other hand, CAT scan was the most likely performed radiologic imaging in obstruction and pain patients, performed in almost 80%, and just over half had a positive finding, similar to what was found in intraoperative finding. When looking at surgical approach, the operative time was around 25 minutes longer in the gastrointestinal bleed group. This could be for a variety of reasons, most likely the type of surgery being performed. Surgeries included laparoscopy, lap-assisted surgery, open surgery, and could have also additionally included visualization, manual palpation, and intraoperative enteroscopy. Overall, small bowel resection was the most common surgical procedure performed in 77% of all patients. 81% of these were performed lap-assisted. Interestingly, intraoperative visual inspection or palpation of the bowel identified 71% of all lesions with no statistical difference between groups. When looking at surgical approach, particularly in the gastrointestinal bleed group, the majority of patients represented in blue underwent a small bowel resection, which is about 90%. Of these, 56% were able to be approached lap-assisted. However, 4 were converted to open due to need for better visualization. There's more surgical variety in the obstruction and pain group with exploration, additional procedures such as appendectomy or diverticulectomy. But again, the majority underwent a small bowel resection, a majority of which were lap-assisted and converted to open because of a better visualization. Ileocectomy was performed due to the proximity to the cecum. When looking at intraoperative enteroscopy, 40% of our patients in the GIBA group underwent intraoperative endoscopy, which is significantly greater compared to the obstruction and pain group. And it had a better diagnostic yield, with 18 patients, or 69% of the patients, having either a lesion identified or confirmed. In the obstruction and pain group, however, it had no diagnostic yield, were performed in all explorations, but none of these resulted in any resection. When looking at surgical pathology, there's a wide variety of surgical pathology among our entire cohort. However, the majority of patients in the GI bleed anemia group, represented in light blue, had an angioectasia in 27% of all patients. On the other hand, carcinoid and Meckel's and small bowel diverticula represented 50% of the pathology seen in the obstruction and pain group. When looking at follow-up symptoms, hospital length of stay, return to OR, 30-day complications or readmissions were similar between both groups. We looked at our follow-up symptoms, our recurrent symptoms similar to patients' their initial presentation. 21% in each group of all patients had recurrence of their initial symptoms. However, when specifically looking at patients who underwent a surgical resection, and particularly in the GI bleed anemia group, 20% of these patients represented with bleed. Interestingly, 9 of these patients had a cause of rebleed due to either angioectasia to some extent. 7 of these patients initially underwent a surgical resection of their small bowel and had an angioectasia identified on their specimen. 2 other patients had small bowel resections. However, one had no pathology found, and the other one had lipoma, but both subsequently developed an angioectasia. In summary, small bowel lesions can be diagnosed and managed based on presenting symptomatology, whether they're gastrointestinal bleed or anemia or obstruction and pain. In patients who have gastrointestinal bleed and anemia, video capsule enteroscopy and intraoperative enteroscopy can be used for diagnostic modalities in these patients. On the other hand, patients who present with obstruction and pain should undergo a CAT scan of the abdomen and pelvis, since it's the single best diagnostic modality within our cohort. Lastly, surgical intervention provides alleviation of symptoms in patients with gastrointestinal bleed and obstruction and pain. However, caution should be warranted to patients who have angioectasias, since their recurrence in our study was around 40% for having recurrent bleeds if an angioectasia was identified in surgical pathology. Therefore, potential endoscopic or medical management should be considered for these patients. Thank you.
Yeah, very thought-provoking. I have a question for you regarding the false negatives in the video capsule endoscopy. Obviously, the elusive GI bleed escapes many of us and can be quite a challenge. Do you have a sense as to how many of them were false negative, and of those, how many ended up in the operating room, and how you dealt with those patients?
So I didn't particularly look at the false negatives. Overall in the literature, the false negative rate of a capsule endoscopy is around 2%, usually quite rare. In these patients, we were just mostly looking at how the positive findings and our true positive findings. In leading to them to the operating room, there were actually multiple types of, not interventions, but endoscopic workup as well. So a lot of the patients had multiple workup. So either they had a capsule in addition to having a spirus, or potentially a double balloon enteroscopy. That'd be something for us to look forward to.
And you said that 70% of the patients at the time of laparoscopy actually had some identifiable lesion, yet you did 40% of the time you did intraoperative enteroscopy. What was there's a bit of a disconnect.
Sure. So some of those patients, they had confirmed lesion that we had suspected. So 35% of the patients that underwent intraoperative enteroscopy, there was a concern from manual palpation that there was a potential lesion. The remaining percentage, there was an ink-marked area, so we just wanted to make sure that that was accurate. And sometimes they were performed to also confirm for additional lesions as well. However, so that kind of overlap existed in that 40%. So they were seen, but then we also were able to confirm those lesions through intraoperative enteroscopy.
Great. Any other questions from the floor? Thank you very much.
Thank you so much.